So hello everyone, this is Dr. Singaram, your pediatrics faculty. We are going to discuss about the recall question discussion in the subject of pediatrics asked in this recently conducted INI-CET November 2024 exam. Before I start the discussion, let me just give you my insights about this particular exam. Standard number of questions were asked from the pediatrics part, and also the topics which were covered were the ones which we usually emphasize in the classes, like the previous year topics as well as the most important topics for any subject like milestones, congenital heart disease, and those topics. Okay. And regarding the pattern of questions, it was a standard pattern according to INI-CET. However, it was more of direct question this time compared to lengthy question. That means the clinical scenarios were comparatively lesser in comparison to the previous INI-CET exams. But of course, the topics covered were almost the usual topics which we expect in an INI-CET exam level. So with that introduction, we will start the discussion now. Now coming to the first question, it is a question about milestone. A child is able to copy a cross, tell stories, and goes to toilet alone. What is the probable age of the child as per the development attained? This is a very straightforward question. If you look at the milestone, copying a cross, telling a story, and going to toilet alone, all will be fitting into the age of 4 years. Okay, this is a very direct question. So I'm going to put up some information about the key milestones attained at the age of 4 years. This is from Nelson textbook of pediatrics. Look at the first one, motor milestone. It is hopping on one foot. There is also one more motor milestone, able to go downstairs. Child is able to go downstairs with 1 foot per step. This is also one more milestone attained at the age of 4 years. This is for the motor domain. Next is about the fine motor domain. Imitates construction of a gate of 5 cubes and also able to copy a cross, which was given in the question. Then about language. Child is able to count 4 pennies accurately and also able to tell a story, which was again given in this particular question. And the last one is about the social domain milestone, where the child is able to play interactively with other kids. So this is more of a interactive play happening by the age of 4 years and also role playing. And along with that, child is able to go to the toilet alone, which is also asked in this particular question. Okay. So everything fitting into the age of 4 years, which would be the answer for this particular question. Moving on to the second question, all of the following are included under Diagnostic Criteria of Severe Acute Malnutrition, also called as SAM, except, okay, which is not height for age, weight for height, pedal edema, MUAC means mid upper arm circumference less than 11.5 centimeter. Let us look at the options from the last. Mid upper arm circumference less than 11.5 centimeter is definitely included under SAM and cannot be the answer for the question. Please remember the age group in which we apply this criteria for SAM children is from 6 months to 5 years. 6 months to 5 years. Presence of pedal edema, of course, bipedal edema or both leg edema is also included under the criteria for SAM and cannot be the answer for this question. Then weight for height, that is also included in the criteria. And what does the criteria say? Weight for height less than or below minus 3 standard deviation is what is called severe acute malnutrition. So that is also included and cannot be the answer. So the obvious answer for this question is height for age. When the height for age is low, we call it as chronic malnutrition and not as acute malnutrition. That would be the obvious answer for this particular question. So these 3 things I have told for SAM, and out of the 3, how many should be present to be called as SAM? Any one of this present itself will be sufficient to make a diagnosis of severe acute malnutrition. That is also one of your previous year questions. So this question answer is very clear. It is height for age is not included under the criteria for SAM children. Okay, so that is something very clear. Moving on to the third question. This is a clinical scenario question where we have to analyze the question in terms of clinical findings as well as the lab findings also. This is a 2-week-old baby who is presenting with a history of epistaxis and recurrent rectal bleeding. So something like repeated bleeding manifestations are noted. And one more is there is also parents complaining of the history that there is a bleeding from the umbilicus since birth. So multiple areas there is bleeding, epistaxis, recurrent rectal bleeding as well as umbilical bleeding. So whenever you have a child with repeated bleeding manifestation, you have to perform the coagulation testing. Here also we have done that, and lab investigation revealed normal prothrombin time, normal thrombin time, normal partial thromboplastin time, normal platelet count as well as normal function of the platelet. So that means the basic workup of the coagulation or bleeding disorder is actually normal. Platelet functions are normal, PT-TT, APTT is normal, and platelet count is also normal. Now, what would be the answer for the question? For that only, a very important clue is given at the end. What is that? Look at the test which is turned out to be positive in this child. What is that? Urea clot solubility testing is positive. This one finding is sufficient to conclude the diagnosis as what factor deficiency? Yes, it is a fibrin stabilizing factor or clot stabilizing factor. What is that? Factor 13. That is the likely deficiency in this particular child. First of all, what is this factor 13? As I already told you, it is a fibrin stabilizing factor, also called clot stabilizing factor. So the role of this factor starts after the formation of clot. That is why till the formation of the clot or till the production of fibrin, everything is not affected. So that is why PT, APTT is normal in this particular condition. So see this, PT and APTT reflect only till fibrin formation, which is actually normal in this child. That is why they are normal in this particular child. And PT, APTT never measures cross-linking, which is actually done by factor 8. This cross-linking is a mechanism for stabilization of the clot, which is done by the factor 13. That is not assessed by PT or APTT. That's what you can make a note of. So for this particular factor deficiency, we have performed the test itself. What is the name of the test? Clot solubility testing is performed to identify the affected individuals. Okay, right? So that is how we come to the answer for this particular question. Now, a quick note about this factor 13 deficiency. It's a rare clotting factor disorder and it is inherited in an autosomal recessive manner. Okay. The usual bleeding sites are actually given in the question also, and I will just read it. Bleeding from the umbilicus, which is already given in the question. The other sites of bleeding are soft tissue bleeding, surgical bleeds, joint bleeds, as well as sometimes dangerous intracranial bleeds can occur. And out of all this, umbilical bleeding in an infant, small baby, should make you think about the possibility of factor 13 deficiency. And of course, the treatment for this condition is a replacement of the factor 13 in the form of factor 13 concentrates. So that was about factor 13 deficiency, which was asked as a clinical scenario question in this INI-CET exam. Moving on to the next question. It was one more question about severe acute malnutrition, but this time related to primary failure of recovery or primary failure of treatment in an admitted child with severe acute malnutrition. There were some criteria given in the question, and that was matched with the day of the treatment. Can you see day 4, 10 and all is something related to day of treatment in SEM. Okay, failure to regain appetite by day 4, failure to start losing edema by day 4, complete absence of edema by day 10, weight gain of less than 5 grams per day from day 20. Okay, 5 gram per kg per day. Sorry for that, 5 gram per kg per day from day 20. Now, this is purely a factual question where you have to know the facts which will be for primary failure of treatment in case of SEM, and this is the standard criteria we use when you call the patient failing to respond to treatment. Okay, there is something called primary failure to respond and secondary failure to respond. In this question, we'll focus on the primary failure to respond to treatment, which is in the first phase or what we called as the stabilization phase. Okay, right. Failure to regain appetite by day 4. Failure to lose edema. This is starting to lose edema. This is what you have to remember by day 4. Edema still present by day 10. That means what? Completely edema is not resolved by day 10. Please make a note of this. And last one, failure to enter the phase 2. That means the rehabilitation phase, or not gaining more than 5 gram per kg per day by day 10. So you can see 2 criteria related to day 4 and 2 criteria related to day 10. Day 4, failure to regain appetite, failure to start losing edema. Day 10, complete absence of edema and not gaining adequate weight. This is what we call primary failure of treatment. Please remember, day 0 is the starting day of treatment and it is subsequently numbered after that. Okay, right. So going by this, you can see failure to regain appetite by day 4 is in fact a criteria for primary failure to respond to treatment. Failing to start to lose edema by day 4, that is also included. Complete absence of edema by day 10, that is also included. But weight gain of less than 5 gram per kg per day, not from day 20, it was from day 10. You saw that very clearly, which was given in the picture which I was displaying before. So, A, B, and C indicate the failure to respond to treatment. So option A would be the answer for this particular question. Okay, right. So that was about criteria for primary failure of recovery. One more point I want you to remember is the reason for failure of response to treatment is basically due to some untreated or unrecognized infection. That is what should be looked for in this particular child whenever there's a primary failure of treatment response. Okay, right? Failure to respond to treatment. Okay, so that's about this particular question. Moving on to the next question, a very usual question asked about jaundice, which is breast milk jaundice. Okay, breast milk jaundice. You have to find which is true statement about this condition. Okay. See, breast milk jaundice is mainly a benign condition. It's not very dangerous condition. So that is why most of the times treatment may not be required. And if you look at the options, most of the children require phototherapy is obviously a wrong statement. Okay, right. And breastfeeding should not be continued is also wrong because I told you it's mostly a benign condition and it's a very transient or a self-resolving condition. So that is what is the textbook lines which are given. Breastfeeding should be seldom stopped. That means it should not be stopped in case of a breast milk jaundice. So that is also out. Now the reason for this breast milk jaundice is due to some substances in the breast milk which will deconjugate the bilirubin, thereby converting the conjugated bilirubin back to unconjugated bilirubin, thereby increasing the unconjugated bilirubin levels in the body, right? So that is why the last option in this particular question, conjugated hyperbilirubinemia, is also wrong. So by excluding the option, we have already arrived at the answer for the question. What is it? It's a condition due to exclusive breastfeeding with total bilirubin exceeding 10 milligram per deciliter after 3 to 4 weeks of birth. Okay, right? I have come to this answer by excluding the other option. And if you go by the textbook references from OPGATE textbook, the first line under breast milk jaundice itself, can you see what is written? Approximately seen in 3 to 4% of exclusively breastfed babies having TSB. What is TSB? Total serum bilirubin of more than 10 milligram per deciliter beyond 3rd to 4th week of life. Exact same line from OPGATE textbook, the first line given under breast milk jaundice, which is the correct statement for this particular question. Okay. Now, as I told you, there are some substances in the breast milk which will contribute to this, and one of the substances is beta glucuronidase, which causes deconjugation of the conjugated bilirubin. That means it converts the conjugated bilirubin back into unconjugated bilirubin, thereby increasing the levels of unconjugated bilirubin and contributing to jaundice. And please remember, interruption of breastfeeding is seldom required. That means you will never stop breastfeeding. This condition will settle on its own. That is what you need to remember. So it's a transient and a benign condition of neonatal jaundice. So you should not stop breastfeeding. The clear answer is option C for this particular question. Okay, right. So that's about this question. Moving on to the next one. Which of the following is not a feature of cystic fibrosis? Cystic fibrosis is one of the most often repeated topics in your NEET PG as well as INI-CET exam. Every year after year, there is one question definitely asked about cystic fibrosis. So you should know thoroughly for all your upcoming exams. Please make a note of this. Okay, right. So this time it was a very direct one. They asked which is not a manifestation of cystic fibrosis. Nasal polyps are a definite feature of cystic fibrosis. In fact, bilateral nasal polyps are associated with cystic fibrosis. So that cannot be the answer for the question. Biliary atresia is a congenital anomaly situation causing neonatal cholestasis and is not a feature of cystic fibrosis, right? Okay. Meconium ileus is one of the early manifestation of cystic fibrosis characterized by thick meconium not getting excreted, and the baby classically presents with delayed passage of meconium as well as abdominal distension after birth. So that's a true finding in cystic fibrosis. Bleeding diathesis, of course we know it's a correct statement, but can you reason out why it can occur in cystic fibrosis? Remember, in cystic fibrosis there is pancreatic insufficiency, correct? There is pancreatic insufficiency. And as a part of pancreatic insufficiency, there is a fat malabsorption occurs, also called steatorrhea. And also there is a deficiency of fat soluble vitamins. What are they? Vitamin A, D, E and K. This vitamin K deficiency, as we all know, is going to be associated with bleeding manifestations only due to inactivation of clotting factors 2, 7, 9 and 10. So that is why bleeding diathesis can be an association for cystic fibrosis also. Okay, so the clear answer for this particular question is option B. Biliary atresia is not a feature of cystic fibrosis. That's a very straightforward question. Moving on to the next one. This was asked in a recent previous INI-CET exam. What is that? In a child with a congenital heart disease, NADA's criteria includes all of the following except. Okay, right. Now, I have discussed this in the previous recall sessions also. During that time, the question was asking about minor criteria in NADA's criteria. Here, they have generally included the criteria. You should know that NADA's criteria has major criteria and minor criteria. First, let me solve this question and then I'll go to the details of this major and minor criteria. Diastolic murmur any grade is definitely included under NADA's criteria. Increased troponin T is for what? It is for helping in the diagnosis of myocardial infarction, and that cannot be something related to congenital heart disease. So that is out and is not included in the NADA's criteria. Abnormal X-ray is definitely a feature under NADA's criteria, comes under the minor criteria. Congestive cardiac failure features also point towards the possibility of heart disease, and that is also included under NADA's criteria. This is a quick recap of the NADA's criteria, which I have discussed in my previous recall videos also. Major criteria include systolic murmur of grade 3 or more, any diastolic murmur which was given in this question, and also cyanosis. Of course, it's a central cyanosis, and congestive cardiac failure, which was again given in the question. When we move to the minor criteria, it is systolic murmur less than grade 3 and all the abnormal ones. What is that? Abnormal S2, abnormal ECG, abnormal chest X-ray and abnormal BP. Sorry, this is blood pressure, abnormal blood pressure. So all these are included under minor criteria. Okay, right? So that was about the quick recap of minor criteria and major criteria in NADA's criteria. Now tell me how many major and minor should be present to make a diagnosis of congenital heart disease clinically. Yes, it is one major criteria or two minor criteria are essential for indicating the presence of congenital heart disease, right? So the answer for this question is very clear. Troponin T is not included under NADA's criteria. That's it. So moving on to the next question. This was a question about GBS or Gillberry syndrome. All of the following are true statement except. We all know that Gillberry syndrome is a condition of polyneuropathy, and it is following an infection, post-infectious condition. Usually, preceding infection is 10 days before an episode of gastroenteritis caused by Campylobacter jejuni, right? That is what we all know about. Now, as a part of this polyneuropathy, what will happen to the dependent reflexes? It will be absent or decreased. So, look at the first option. Areflexia of the affected limb is a mandatory diagnostic criteria that is true only and cannot be the answer for the question. Second option, plasmapheresis is not preferred in refractory cases. Please remember, the first treatment we give is IVIG for a progressive weakness in Gillberry syndrome. But if IVIG is not effective, plasmapheresis is this next treatment option. So, saying plasmapheresis is not preferred is a wrong option and will be a wrong statement and will be the answer for this particular question. IVIG is definitely the first line of treatment. That's a correct statement. And in fact, albuminocytological dissociation in CSF is characteristic. We all know that when you do the lumbar puncture and the CSF analysis, there is a discrepancy between albumin and cell count. What is that? High albumin or high protein, but cell count are normal. That is what is called albuminocytological dissociation. That is in fact characteristic of Gillberry syndrome. So all the things are correct statement and B is a wrong statement and will be the answer for the question. Now I'll just take you through some points from Nelson textbook of pediatrics to give you more information about this particular topic with relevant to the options given in the question. Number 1 is features needed for diagnosis of Gillberry syndrome. Remember, it's a neuropathy. So it is characterized by muscle weakness. And this weakness is usually involving the legs and the arms, limb muscles. And where does it start? It starts from the legs and goes upwards to the upper part of the body. That's why it's called ascending paralysis or ascending weakness. That is what you have to remember. Okay, right? It's an ascending weakness. Okay, second thing, I've already explained that in the question itself. Absent deep tendon reflex, areflexia, or at least decreased deep tendon reflex is very, very important for making a diagnosis of Gillberry syndrome. That is also correct. Now, moving on to the Next one, that is CSF analysis finding. See the line from the textbook. The dissociation between high CSF protein and lack of cytological response. That means what? Cell count are normal. That is what is called albuminocytological dissociation, also called cytoalbuminological dissociation, in a patient with acute or subacute polyneuropathy is essentially diagnostic of Gillberry syndrome, which was again given in the options in this question. Now, talking about the management or treatment of Gillberry syndrome, I told you for any rapidly progressive weakness, IVIG is a first line treatment of choice. That is intravenous immunoglobulin. If that is not effective, then we can go for the other treatment, which includes plasmapheresis and or immunosuppressive medication. We all know that immunosuppressive drugs are a big group. And in that immunosuppressive drugs, please keep in mind, steroids are not actually effective for improving the weakness. Instead, they will improve with the pain in a patient with Gillberry syndrome. So this is an important point. Among the immunosuppressive medications, steroids are not that helpful to improve the weakness. Please keep that in mind. So with all this discussion, the answer for the question is very clear. It is plasmapheresis is not preferred in refractory cases is a wrong statement, and that would be the answer for this question. Moving on to the next question. It's a very straightforward question. A 4-year-old child was diagnosed with croup. Which of the following is the most common causative organism? Remember, croup is an upper respiratory infection, okay, with an extension to the larynx and trachea also. That is why it's called laryngotracheobronchitis, okay. And this is the typical age group for the croup also. Basically, croup is a viral infection, and we all know that the most common cause for the croup is a para-influenza virus. Para-influenza virus. Now, if you look at the options, para-influenza is not given. That means you have to choose the next common virus associated with the croup. What is that? It's a straightforward one, which is influenza virus. That would be the answer for this particular question, because para-influenza is not given in the options. Now, just a quick recap of the important points I told you. The age group given in the question was actually typical age group. It is from a range of 6 months to 3 years. And croup, being a viral illness, is characterized by low-grade fever. Generally, the child is not very sick. And due to involvement of the larynx, you get stridor. And what is the characteristic cough in croup? Barking cough. Please remember, stridor, barking cough, and low-grade fever are characteristic findings of croup clinically. And if you do the X-ray, you will see the characteristic sign. What is the name of that sign? Steeple sign, which represents the subglottic narrowing, okay, seen in cases of croup. The maximum area of narrowing in the subglottis region, which is what we see as a steeple sign in case of croup. Okay, so that was a clear answer for the question, influenza virus. Moving on to the next question. This is a very factual question. Which of the following causes the closure of ductus arteriosus? We all know that ductus arteriosus is something like a structure connecting the two arteries, namely the aorta and pulmonary artery in the fetal circulation, and after birth, it is going to close. What is the chief factor for the closure? Is it increase in oxygen levels, decrease in the carbon dioxide levels, increase in the pulmonary vascular resistance, or fall in the concentration of catecholamines? What do you think is the answer? Please remember that the main factor for the closure of ductus arteriosus is increase in oxygen. We all know that once the baby starts crying or breathing, where the lungs get the oxygen and give it to the body, there is an increase in the oxygen concentration in the body. This increase in the oxygen concentration causes constriction of the smooth muscles in the wall of the ductus arteriosus, and this constriction of the smooth muscles will result in the closure of the ductus arteriosus. This is the main factor for closure of ductus arteriosus after birth. Please remember, there is also one more factor, two key factors. One is already given, rise in the oxygen concentration in the blood. Second is decrease in the levels of prostaglandin, because prostaglandin is the one which is responsible for maintaining the patency of ductus in fetal circulation, and after birth the prostaglandin level decreases, and that will also contribute to the closure of ductus, but that is the second factor. First factor is always increase in oxygen concentration, and that would be the answer for this particular question. Moving on to the next question. This was about cardiopulmonary resuscitation. Pediatric CPR, okay, is always an important topic for your exam purposes. Okay, right. The question was, which is a true statement? chest compression at the rate of 30:2. Whenever you maintain a ratio or a rate, it is chest compression with ventilation ratio. That is what they are asking about. 30:2 with 2 rescuers. 30:2 is okay, but it is not for 2 rescuer. It is for a single rescuer. That means one person. And actually, what is the correct version? If there are 2 rescuers, then the ratio should be 15:2. Please remember this. That is why. So it's a wrong one and cannot be the answer for the question, right? For single rescuer, it is 30:2. 2 rescuers, it is 15:2. Right? Adenosine is via intraosseous is preferred over other method. First of all, adenosine is not even used in the management of pediatric CPR. Adenosine is for paroxysmal supraventricular tachycardia in the intravenous route. We all know about it. So anyway, that is wrong and cannot be the answer for the question. Look at the third option. While chest compression, depth must be at least 1/3 of the AP diameter of the child's chest. This is a correct statement and that would be the answer for this question. We always say the depth of compression should be at least 1/3 of the diameter of the chest in terms of AP diameter. That is what. So that's a correct statement only. Adrenaline is given in the dose of 0.01 milligram per kg IV or IO in 1 in 1000 concentration. Up to this part, everything is okay. Adrenaline is given 0.01 mg per kg IV or IO. That is all okay. But it is not 1 in 1000 concentration. How much? It is 1 in 10,000 concentration. Always we have to dilute the adrenaline to this concentration and then only you have to use it during resuscitation. So that is what is wrong and cannot be the answer for the question. So the very clear answer for this question is option C only. Now, let me take you quickly through some important points regarding this pediatric CPR with relevant to the options given in the question. First is about chest compression. What is the usual rate of chest compression we maintain? It is approximately 100 to 120 per minute. That's what you need to know about. Okay. Next is the depth of compression. I told you it is at least 1/3 of the AP diameter of the chest. Please remember this is approximately 4 centimeter in an infant and after infancy it is 5 centimeter in children. Approximate depth of compression. Okay, right. Then third one, after you do one chest compression, you should allow some time for the chest to fully recoil because full recoil of the chest only facilitates the venous return to the heart for the next compression. So please remember this. Okay, right? You should always allow full recoil after each chest compression. Okay, right. Next is about adrenaline pediatric resuscitation. We all know that it's one of the life-saving medications. So you have to know all details about adrenaline, which was also asked in this exam. Number one is the dose. As I already told you, it is 0.01 milligram per kilogram. Or you can also remember in terms of ml per kg, 0.1 ml per kg. But always remember it is 1 in 10,000 dilution. Please make a note of this. And every dose, maximum dose of adrenaline is 1 milligram. Don't forget this. Maximum dose of adrenaline is 1 milligram. And strength, I've already told you, it is 1 in 10,000 will be the strength. And you can give it by either route. IV is a preferred one or intraosseous route. Okay, IV or IO. However, you can give it through endotracheal tube, that is ET route, if there is no IV or IV access, which could be obtained. That is a alternative route, but least preferred in fact. Why? Because erratic absorption of the adrenaline occurs through endotracheal route. So we don't usually prefer, but as a last chance, as a last resort, we can give that route if no IV or IV access is available. Okay, right. And also you can repeat the dose of adrenaline every 3 to 5 minutes as needed. Okay, suppose the heart rate is not increasing, then you can repeat every 3 to 5 minutes. So these are the must-know points about adrenaline in pediatric resuscitation. So with that, the question answer is completed. Wherein option C, chest compression definitely should be at least 1/3 of the AP diameter of the chest. So with that, we have come to the conclusion of the discussion of INI-CET questions in November 2024 session in the subject of pediatrics. I hope this discussion was useful. If you have any comments or any modifications in the question or any clarifications to be addressed, please put it up in the comment section below. Thank you and all the best.